Welcome to our latest People AMR webinar. We're just letting people in the room and making sure that everyone's on mute. Just to remind everyone today that we are recording the webinar. So please keep your camera off if you don't want your image to be recorded. If you'd like to ask questions at the end, you can do so by raising your hand and put your camera on, or writing questions in the chat. So I'm really happy to welcome Noor to come and speak to us today. I met Noor just over a year ago when she was starting this project, and it sounded really fascinating at the time. So I said, please come back and speak to the People AMR Network when you finish the project, which is exactly what she's doing now. So Noor is a doctor and researcher in Liverpool, and she's going to tell us today about a really exciting project, which is a great example of inclusive research. And we were talking just before we started about how important inclusive research is now, and making sure we include diverse people in our research to make sure that we can get the benefits of AMR research going out to different communities and populations. So Noor, thank you very much for having us coming along today, and I'll hand over to you to share your slides.
Thank you so much for having me today, and I hope the presentation will have like a good impact on everyone. So can you see the slide? Just to make sure that it's shared.
Yes, we can see it fine, thank you.
Okay, so the project we are talking about today is funded by UK RA, but it's embedded in a larger project called Recite, and Recite is funded by a HRC. I have put some links here, so when the presentation is shared, anyone can just click on the link and read further information. So just a quick background why we have chosen AMR in refugees and asylum seekers, because the evidence, and this is one of a report by WHO capturing the evidence on access to essential antibiotic in refugees and migrant population, says that refugees and migrants have a high trust in antibiotic because they use them in their home countries, and they believe it's a quick relief or a quick fix for most of the symptoms. Some people even prefer injectable antibiotic or specific type of antibiotic. And sometimes, like a stigma and cultural norms, push refugees and migrants to seek antibiotic rather to go to like the formal NHS or the formal health system. And this is where we thought, okay, this is a health equity issue we want to tackle. But again, before I talk about this specific AMR team, I want to talk about the Recite and the model that we are working on. So Recite is trying to tackle health inequity issues, which is, we always say, it's a wicked problem. It's rooted in misinformation, in community trauma, in stigma, and fear and mistrust. It's not easy to tackle, but collaboration is the core of this one. It's a 3-year funded, as I said, AHRC. This is the final year, unfortunately, of it. It's data-driven, but we always say we need a creative solution. We use storytelling. We use evidence to convince policymaker and commissioner on the benefit of using this type of work. We have loads of partners with us, but this one is led by Liverpool School of Tropical Medicine, LSTM. This is a few assets that we developed before. You can see how creative it is. So from breast cancer campaign to MMR vaccination to different things. And within Recite, we have this, we call it the Wheel of Change. And within that, you can see 5 pillars. The first pillar is the what's your story. So this is where there were some series of workshops with people with lived experience sharing their stories about health inequity issue. The second pillar is the core of it. We call it the KIT, or the Community Innovation Team, where communities work together with health provider to tackle health inequity issue, and this is where the MR team will sit. The third one is the creative health exchange, and this is where we have like a large event where we connect healthy provider with community organization and creative to work together and collaborate. We had one last year and we will have one this year as well. So I will share the invitation once we have it booked. And then the fourth pillar is the advocacy network. We thought that sometimes there is some structural issues that we cannot tackle, and this is where we need advocacy, a strong advocacy, where we work with the policymaker and people who actually can make the change to address the root cause of the health inequity issue. And the last one is the learning event. And this is where we call a celebration of learning. For the site, the large learning event will be on January 2027. Also, I can share the invitation later where all the team that's working on this project will share all the learning. This is from the learning event from a previous project, but this is how it looked like. It's very active, very vibrant, very colorful. Within Recite, we have loads of teams now. If you have seen this map before, so we have a 12 community innovation team or a 12 team, and the focus is quite diverse. Within that, we have the the antimicrobial resistant team in Tuxtis, but also we have team looking at MMR vaccination, we have whooping cough vaccination, we have lung cancer, childhood nutrition, epilepsy, high intensity user, youth mental health, dementia, suicide. So you can see it's a bit of diverse, but all of them use the same model that we are proposing within Recite, which is our community-led approach. Within the KIT or the Community Innovation Team, we always say that we gather the right people on the table. So we'll have health provider, we will have community organization, we will have community leaders or champions or volunteer. We will have other stakeholders from public health or other places. We will have also creative or art organization, and those will work together in a partnership to analyze and use local data. And from that, they will collect local insight and then develop a creative community-led solution for the problem they are looking for. And if you think about it, it's a form of quality improvement project, because what we actually do, we identify the problem, but the problem is in a specific place. For example, for this part is in Liverpool between refugees and asylum seeker, and then we develop a problem statement. Then we will work with the team to identify the root cause analysis and to understand what's the root of this problem. Then we will develop solution to address this problem, but a solution that should be creative. And the last bit, we will implement the solution and try to monitor the change or the impact of it. Within the AMR team, we have BC24 or Primary Care 24, who are responsible for the initial assessment for all the asylum seekers in Liverpool. We have also NHS Merseyside Social Inclusion Team, and we have people with lived experience, or we call them AMR champions. But this is not only this one, because we have a larger partnership with other. So we have Abercrombie Central Pharmacy, we have Merseyside Refugee Support Network, Refugee Women Connect, Care for Calais, British Red Cross, and Brownlow Health. And the objective of this project was first to identify the enabler and barrier to proper antibiotic use between asylum seeker refugees population in Liverpool, and then use the finding from this one to develop information, education, communication campaign, which we call it Healthy Liverpool, and then to evaluate the impact of this campaign on the change of the attitude and the knowledge and the practice of the antibiotic use. We always say that our model, we avoid using the consultancy top to down, and we use the upside down model, which is from down to above. So if you have a look at this graph, you will see that there is two person helping each other, like literally dragging each other. And this is where the KIT or the community innovation team work together. So we have the primary healthcare, we have the people with lived experience as LSTM, and we have our partner CDI or Capacity Development International. We provide capacity building, mentorship, training, and then each team will, as we said, will do a behavioral insight. And then from that behavioral insight, they will design solution, and then they will try to monitor the solution to see what's the impact of it. And the end part of it is the knowledge exchange, which we are here to do. So, going to the practical part of this presentation, what we did. First, we try to gain insight on the antibiotic use and knowledge within Liverpool because we have that evidence from the WHO, but we wanted a hyper-local evidence to know what's there in Liverpool specifically. So the team did a survey with 108 asylum seekers um, who mostly reside in Berley Court. So this is one of the initial accommodation sites. And then they did a group discussion with 6 asylum seekers on their behavior and to explore how they use antibiotic. And they also surveyed around 19 health providers, in addition to a pharmacist. From this behavioral insight, we found many findings, but I would say the most significant one was the access issue. So 87% of participants reported that they have difficulty in accessing healthcare. And this strike for us because if they cannot access health services, if they don't know how to access health services, we cannot go directly and talk to them about antibiotic because it doesn't make sense for us. There is also, like all of us know, the long waiting time. There is also a confirmation about the self-management strategies where they use home remedies. Some of them use also antibiotic from different places or buy antibiotic abroad and so. And there is also gap and misconception in the use of antibiotic itself. So what we did, we worked with the team on a workshop to do root cause analysis. And again, this is the model that we are working on. From the root cause analysis, there was one of it is the lack of the knowledge about the NHS again. And I don't want to read it all, but if you can see the root of it was lack of tailored and acceptable health information for them, lack of education initiative, weak design of awareness campaign. And this is where we thought, okay, then we want to do a very hyper-local creative campaign. And we used also peer educational session to tackle those problems. There was also lack of knowledge about AMR, as we expected, and there is unmet expectation just because many of them are used to take antibiotic over the counter, and they come here. Um, it become like a frustration for them because they cannot take antibiotic. So they will try to overcome this by using antibiotic from a friend, buying it abroad, and so. And there is also the GB surgeries and pharmacies not explaining how to take medication actually. And even like some people did not know how, what does the dose mean, like if you say a tablespoon or something like this. And this is where we did an educational awareness film as well to know that this is the antibiotic, this is how to use it. And there is also lack of follow-up on medication use in the UK itself. So this was what we found in the surveys, in the interviews, and so. And from this, we create a Stay Healthy Liverpool campaign. Within the campaign itself, the team did a 5-minute health educational film. I will show it now. Hopefully, we have some time for it. And then we have also information leaflet poster detailing how and where to access health services in Liverpool, specifically if you live in, for example, Berley Court or Greenbank. So we make we made it hyper local, so people who live in initial accommodation can like take the leaflet and the map and see where they can go, how to access her services specifically. And we also train 9 AMR champion from refugee and asylum seeker themselves, because we believe if we only like provide them with leaflet or map, it will not work alone. We need those conversations from trusted messenger to talk to them in their own language and their own culture. Those are our brilliant champions. We, at the end of the project, we made like an appreciation day for them and give them awards. They really appreciate it. This is the leaflet. So this is the front part of it. And if you can see, it just tried to be very creative, but very simple. So here it listed that the fear and the understanding that we know everything is new for you. And then here it say, if you live, for example, in Berley Court, the closest pharmacy for you is this, the closest GP practice for you is this. If you live in Science House, if you live in Greenbank or Roxas Grove, so it's very hyper local for them. It also provides them with extra layer of information. For example, the walk-in center. And we know from working with refugees and asylum seeker, loads don't know what's the walk-in center. And it's say, for example, for you that you can call those numbers. If there is like an emergency, where to go. If you are pregnant, where to go. Sexual health, where to go. And a bit about a free prescription medication, because some people don't know what HC2 certificate. And for those who doesn't know that, it's a certificate provided for asylum seeker refugees that help them in a way to prove that they don't have to pay for the prescription. Some people don't know that. Some people feel stigma of asking of getting a free prescription. So in a way, it proved for them that this is your right. And also we put some information about caring chemist. So what's the most common signs or symptoms that you can get a treatment directly from the pharmacy. So like cough, diarrhea, skin problem, urinary problem, head pain, and throat. And just a small bit about antibiotic, because again, there is a larger access issue, so we cannot go directly to them and say something about antibiotic. We need to educate them about the whole issue. And on the back of this one, there is this map. So, and the map was co-created with the asylum seeker and refugees themselves to ask them, for example, if you are in Berley Court, what will be the most prominent landmark? So, for example, for Muslims, there is Al-Rahma Mosque. For Christian, there is the Anglican Cathedral, and there is the Women's Hospital, and there is like the Royal Hospital. And the creative who did that did it in a brilliant way that it looked very visual and very real, so you can know. Also within the Science House and within the Croxy and group. And when we print that one, so anyone who can get this map, we got some feedback from people saying that it's very much easy. It's easier than Google Map. We can keep it with us in our pocket. And it's that visual. But also we print it in a large Fomex and we install it in the initial accommodation site. So refugee, asylum seeker who actually reside there can know and just have a look at it. This is one of the film created. It's around 5 minutes, but we created in a way that people can understand what's happening, even if they cannot talk English or speak English. So I hope I will try to play it now. I hope the audio is working.
In our communities, we all want to stay healthy and protect our loved ones, but there is a big problem we need to talk about, and this is with antibiotics. Antibiotics are often misused, and this can harm your health and the health of others. In the UK, you can only get antibiotics by being given a prescription by a doctor or other qualified healthcare practitioner. You can't buy antibiotics at a shop, pharmacy or market. This is a prescription, The doctor will write on it the medication they are prescribing for you. Antibiotics are only prescribed for bacterial infections. They don't work with infections caused by viruses, which is why you won't always be given a prescription for things like colds and sore throats. You then take the prescription to the pharmacy to collect your medication, or it may be sent there electronically. It is your responsibility to collect the medication from the pharmacy. And please note, the medication is free. When you're given antibiotics, it's important to follow the instructions and take the full course. Don't hold on to some of the pills for the future. Antibiotics are not like money. They can't be saved for another time. Sometimes people use antibiotics when they don't need them. Maybe because a friend or someone on social media has said it's okay. This is wrong. Taking antibiotics incorrectly or without being seen by a healthcare practitioner can be dangerous. Misusing antibiotics now can create antibiotic resistance in the future. This means that antibiotics will stop working and we won't be able to treat some infections. Antibiotic medication comes in different forms. Tablets and capsules can be different colours, shapes and sizes and come in different strengths. Some antibiotics are in 100mg dose, or they may be 250 or 500mg, or a different dose completely. Antibiotics can come in liquid form, in different colours and size bottles. Often children are given antibiotics as a liquid medicine. The pharmacist will tell you how to take it and will give you either a 5ml spoon or a measuring cup with lines on the side of the cup, showing doses from 5ml to 30ml. Pharmacists will tell you how much to take and it will be written on the label. Antibiotics can also come in a cream or ointment form. This is normally given for skin infections. Only apply these to the infected area. The pharmacist will tell you the correct dosage and it will also be written on the label. Some liquid antibiotic medicines need to be stored in the fridge. Please read the label on the bottle and shake any liquid medication before you take it. Timing is important for the antibiotic to work effectively. If you are told to take the antibiotic once a day or every 4, 6 or 8 hours, it is important to take them exactly at that time, because different antibiotics are effective in your body for different lengths of time. Some antibiotics should be taken before or after food. Please check this with the pharmacist when you collect your medication. Remember, do not share your antibiotics with anyone else. Take the full course, even if you feel better partway through the course. If you stop before completing the course, even though you feel better, the infection may still be there and it may come back. For common illnesses like colds and coughs, remember your own home remedies. Drink plenty and rest, and talk to the pharmacist about over-the-counter medications. If you use antibiotics wisely and in a responsible way, then together we can stop the misuse of antibiotics and protect your health and the health of your community and future generations.
So this film was, the transcript of the film was actually written by a pharmacist who was an asylum seeker with us. And she was part of the actors here. All the people who have been filmed are asylum seekers and refugees as well. And they helped in creating this amazing film. When we so this was the educational part of the film, but also as we are a creative health approach, we always try to do a bit of more. So one of the champions and the refugees and asylum seeker was a poet, and he wrote a small poem for us about antibiotic use. So we'll just want to share it because we thought it's close to the heart as well.
If we use them wrong, they will stop their fight. Germs grow strong both day and night. The cure, what we need, will go away. And thickness means another day. You want to know the secret or the solution? Please use antibiotics the proper way. Do you hear me? Come again? Brilliant.
So, all the assets are amazing, but they cannot work by themselves. And we wanted to make sure that people actually can see them and can understand what's happening there. And this is why we have 9 community champions or AMR champions who speak different languages, even like we have different dialects. So within Arabic speaker, we have people from different countries as well to make sure that we are inclusive. And when we choose those champion, we actually try to choose them from the initial accommodation side, so they will become so they are already trusted people within their own community, and we build their capacity. So we train them on 4 stages of training. So the first stage was to build a shared understanding because some of them have a health background. So we have 2 are pharmacists, but some of them don't have even like a health background. We have journalists, we have people who have agricultural experience. So it's a bit of everything. So we try to give them the basic information about antibiotic use, AMR, why it's important. But on the other hand, we always make sure to safenet them. So saying that you are not a health provider, you cannot like give them a medical advice or so, and we give them like some information where to guide them if they needed further information. And then we explore cultural belief. And because we had people from different cultures, so we have people from Sudan, from Syria, from Eritrea, from Iran, and from Somalia. We thought that people come with different culture and different backgrounds, so we wanted to do like a cultural icebreak activity for the champion themselves to know that we are different, we come from different background, and we want to understand each other and to build that trust. And then we develop a peer-to-peer educational skills. So we work with them to educate them how to do communication skills, how to do active listening, empathy, open question, how to explain AMR in their own languages. And then we did a role play with them, and we asked them to do role play with each other as well. So they, in a way, they will try what it will look like actually in real life. This is one of the picture that one of the senior community inclusion worker was doing the cultural sensitivity and ice-breaking activity. And then we went out to the community with them. Myself and my colleague Rida, he sent his apologies today, he couldn't join, but we are both a community mobilizer, which means that we help people to connect with the communities. We identify community venues and places where our research can go there. So we approach around 160, 170 asylum seeker refugees in 11 different community locations across Liverpool with the champions. So the champion will come with us. They will start talking to people. They will do a pre-survey. Within that, we will try to measure the knowledge that they have and the behavior of the antibiotic use. And then the champion will show them the film, will show them the leaflet, and they will start talking to them in their own languages. And then also we include mixed gender, women only, informal outdoor session. So whatever available. We went to some of the clinics in the waiting area. We went to, for example, one of the community organization called Refugee Women Connect. They have like a women only drop-in session. So went there with women. We went to ESOL classes with women, so English as a second language. We went to food pantries. So whatever is available within Liverpool, we just went there. And in a way, we created a safe and accessible space for open conversation and peer support for those champions and the people within their community. Within the pre-survey, this is the finding that we found. So around 68% of the asylum seeker refugees thinks that antibiotic can treat cold and flu. 40% are not confident about when antibiotics are needed. 49% stop antibiotic early if they feel better. 43% think it's okay to take antibiotic from friend or family, and 30% save antibiotic for the next time. So this is from the pre-survey. And we hope that after those people have been exposed to the educational material, to the leaflet, talk to the champion, we're still collecting the post survey, but we hope that there is at least change in the knowledge gap and the behavior, hopefully. It just like to have for you to have a look about how does the survey look like. So it's very simple, just a few questions. And again, the champion will be there helping in the translation and like filling up the survey. And we made sure that it's the same survey from the pre and post. We just added this part, which is section 2.3. Have you seen this leaflet before? Just to make sure that we are measuring the change from the people who are exposed to the educational material. I think that's it from my side. I hope that one was a really light presentation, but also helpful for everyone to think about how to include refugees and asylum seekers in our research. And again, if I want to give you just two reflections from my side, being part of this work. The importance of collaboration. So we couldn't do that alone. We are an research institute. We have like people who have experience in research, experience in medical and public health. We know how to reach the community, but we cannot do that alone. We wanted that trusted channel from community organization, third sector, community champion themselves. I think the other part, we want to acknowledge that this work cannot be done without the AMR champion or the community champion themselves, because they were our anchor for this work. So they actually went out to the community, and they were co-creating the asset with us. So even like the leaflet, the film, everything, this cannot be done without them. And then afterward, they went out to the community and speak to their own community about all the information that we have found. And another reflection is, if you think about it, and from the observation we found, those champions also benefit from this work because most of them, they were asylum seeker refugees. They recently joined Liverpool. They don't know how to navigate the system. They don't know a lot of people here. So being part of this project helped them build their confidence, helped them, some of them even like got further jobs, which is amazing because if you think about it, we were like just a bridge for them to continue their life or professional life. That's it from my side. I hope everyone liked the presentation. This is my contact details, and if you wanted also further information, we have the Recite LSTM website where you can find a newsletter, you can find on the updated information. And if you're interested to know more about the community innovation team, the 12 team that I mentioned before, there is an interim report here that have like a section about each team. Thank you.
That's fantastic, Noor. Thank you ever so much. That's such a clear presentation. And the trouble is, I think you make it all look very smooth and easy, but I can imagine the amount of work that went into everything behind the scenes, not just making the materials, but as you say, engaging with people on the ground as well and working with the community and innovation teams. It's a fantastic example of how to get to those underserved groups, which is brilliant. So yes, questions for Noor are very welcome. So raise your hand or put something in the chat. I see Monzi's put something in the chat and she's had to leave to go off to something else, but she had a question about communicating with those people where English language is a barrier. and things you did to get around that, or presumably the AMR champions help with that, and presumably they spoke different languages themselves.
Yeah, so there are 9 champions who speak around 7 different languages. But also, if you think about it, both myself and my colleague are bilingual as well. So we speak Arabic, English, Arabic and different dialect as well, and French. So we can, in a way, try to help also the MR champions. So it was a collective effort.
Do you think that helps in terms of people trusting the research team?
Yeah, of course. So within LSTM, we have now 3, but we had 4 community mobilizer. And the role of the community mobilizer is in a way connecting the researcher with the community, but also helping the research team to understand the communities around us. And this is where, for example, my experience, my other colleague experience is crucial because all of our research is within Liverpool, Sefton, and Knowsley. And you wanted somebody from the community who can speak the language or share the culture or, in a way, connect you. Because we know sometimes as researcher, we don't use the correct terms. Sometimes even we use complicated forms and things like that. So one of our many roles is to be the mediator in that bit.
Fabulous. Thank you. Marta has got a question.
I mean, thank you. It's a fantastic work, and I think, like Sarah said, you made it sound like it was done, so easily. But I can imagine for each stage, you must have had lots of challenges. And I've got kind of lots of questions, but it's just more around, for example, this video and the poem, which was really, really a great example of doing something beyond the leaflet and community engagement. But I was wondering, how did you, I suppose, convince these communities to engage with you so readily, to commit so much time to this? I can imagine this must have taken a bit of time, and that's one thing. And then something as powerful as that person doing the poem, could that be used beyond your geographical area, and kind of thinking how others can use human experience? So I will restrain myself to these 2 questions.
Yeah, no, it's okay. I'm happy also to answer later if you want to email me. So we'll answer the second question first. Yes, of course, all the films are in YouTube, so you can share them widely within your site. And we got the permission from Jimay, who's the poet, to share it widely. So this is one thing. The first question, it took a lot of time, I would say. But again, this is not LSTM work, it's the collaboration work. So if you think about it, PC24, the primary care 24, are responsible for the initial accommodation site. They have health provider who are familial faces who actually have a clinic in the initial accommodation site. So all the asylum seeker will come to the clinic to get the initial assessment, to get medication and so. So if you think about it, they are trusted faces. So we use this as a channel to recruit asylum seeker refugees. But also on the other hand, the champions themselves were early on the team. So they actually talk to the people within the asylum seeker initial accommodation. They encourage people to be part on it. And I can just remember the day of the filming, we had around 30 people attending. We went to the coffee shop, we went to the park to film that bit. We had only 2 days of filming, but I think the work behind that took loads of time. And if you think from practicality point of view, you should also provide some thank you token for them. So whoever needed a transport, we provided travel reimbursement for them. We provided lunch, we provided refreshment, so that kind of thing as well. And we acknowledge all the people in the film as well. So in a way, acknowledgement, the warm welcome and culture, the trusted channel, all of them work together. Yeah, that's it.
I was wondering whether you got any kind of queries or pushback from people when you were kind of giving them this new information, because sometimes it is very at odds with what they're used to. And kind of how you overcome that, because when we do PPI in general, PPI people might make suggestions to us which don't fit with the kind of clinical guidelines, as it were. So I wonder how those discussions went, if they came up.
Yeah, so to be honest, again, we had a mixture of dissemination, I would say. So some of them we went to the clinic and talked to the people in the waiting area. Some of them were like a pre-established group, like for English classes or a drop-in, and we went there and talked to them. I wouldn't say we had a pushback. People were happy to listen. And because we tried to bring people who speak their own languages or different languages, and if we talk in a group, then we will provide one-to-one also one-to-one conversation. So it was, in a way, people felt happy to engage and they wanted to ask more. Sometimes they ask more questions that we can answer ourselves. So we'll try to guide them where to go and who to ask exactly. And it felt like people are actually missing that part of like one-to-one conversation because of the system and everything. Yeah.
Yeah, that's nice. So yes, you're kind of acting as a route for answering other questions about possible other topics as well, which is good. You had something about home remedies in the video, and you
Yeah.
mentioned remedies when you did the kind of exploratory work in under Objective 1. And the video talks about drink and rest, which is kind of fairly standard. Did you find that people use any other home remedies that may or may not be evidence-based?
Yeah, so because when we did the group discussion with some of the asylum seeker before, they mentioned a lot of herbs and things they use back home. Some of them they bought it like overseas. Some of them they can buy it from the international shops here. But I think in the film itself, we try to overcome any complications. So we just mention like tea and honey because we don't want to advise something that could have like a risk on the health and so. But you will be surprised on how many things people choose.
Sure. I mean, the video is very good, and people shouldn't underestimate how hard it is to write a script for a video like that, and in being very careful how you choose your words and what information you put in and what information you leave
Yeah,
out.
and to be honest, we had like amazing people because we have the pharmacist from Sudan who wrote the transcript in addition to advanced nurse practitioner who have worked with BC24 since years, and she have like loads of experience working with asylum seeker refugees. So this is where we have like that bit. And then as a team, we reviewed the transcript together. We added few bits, we removed few bits. So it was a teamwork as well.
And I know you've got health psychology expertise in the team, because Reda, I think, has got a health
Yeah.
psychology background. Have you got a logic model for these intervention materials? Have you used behavior change theories into sort of informing the script for the video?
To be honest, we had a lot of discussion about it. We tried to make it as simple as possible. I wish Rida was here today, but wish him luck. He's submitting his PhD, so and his Viva soon. But I think in a way we did not use like a specific framework or a model. But of course, this was informed by Rida experience, and he had loads of experience working with refugees and asylum seeker, along with his health psychology thing. So whenever there was something that we are not sure about, we ask him and he advised on that.
Yeah, and I suppose you've got the questions in your evaluation which you're asking about mechanisms of change in there anyway. So you've
Yeah.
already got the hypothesis of what you think you're trying to change. Fabulous. That's great. Are there any other questions from Noor from anyone else on the call? Marta.
Yes, so I think just building on Sarah's point about the self-care. So you are seeing similar things in the work we are doing with immigrants, so not asylum seekers or refugees, but the leaflet you have shown, it seems to me that the aim is to kind of raise people's understanding of how healthcare system works here. And I take your point that we can't include the things which are not evidence-based, which people use in their own countries. But was the idea that this leaflet could include some of the cultural beliefs or culturally important information, which would make it more trustworthy. Because I suppose it's kind of the two aims, bringing the understanding of the healthcare system to these people, but also, I suppose, acknowledging that they may also have worthwhile attempts at looking after their health, which, you know, they could still use, like, I don't know, honey or whatever, which, so do you see my point? So I suppose, is there anything attempt to kind of make it more culturally appropriate, just to acknowledge that they may have different things which may actually work as well?
Yeah, so the whole idea of the leaflet and the map was, as you said, to help them how to navigate the system, because when we did the behavioral insight, we found that 87% of the asylum seeker refugees don't know how to access health services in the UK. And we want it to be a resource that can be used for years. And you know that asylum seeker cohort change over time, so depending on the global event. And so in a way, this is the baseline. But we have the champion who have come from different countries, from different culture, from different languages, and they are our own channel. So if you think about it, if they go, for example, to people from Syria or from the Middle East and talked to them about antibiotic and how to access health services, and so this can emerge in the discussion, and this is where the champion can advise them within their limited knowledge again, because we told them not to go like beyond that as well. Also, we have like some pharmacists and people with health background, but we wanted to safeguard them in a way.
Really? So we've got a question from Fong.
Hello. Yeah, thanks for that presentation. I just had a question about when you mentioned using creative arts methods. I think that I see this more and more among, like, when working with different ethnic groups, and it shows in the outputs that you produce, like a video and poetry. I wonder if there's any other methods that you used, you know, when working with the participants, and also if you think there's other outputs that we can create that are creative in art space and that resonate with the communities you work with.
Do you mean for this specific AMR team, or in general for the whole Recite project? Because the whole Recite project is a creative health project, if you think about it. So I cannot now include all the creative method we are using there because it's humongous, but I would say we have drama, we have puppet show, we have bob show, we have films, we have AI generated films, we have what else we have? So we have different type of stories. So one of the team is working with kids about nutrition and healthy choices, and so, and they have created a story. They have created some workshop with parents and workshop with teacher and workshop with children in the schools. So again, I would encourage you to read the Antirium report at the end of the because this only gives you an idea about a few of the teams. Some of them already started in the last few months, so they still did not develop their own asset. So we have, for example, one team looking at epilepsy in pregnant women and sexual reproductive health. We have one team looking at, it's the only youth-led team, so youth between 16 and 18, and they decided to focus on type 2 DM and health lifestyle. And we have other team focusing on cancer screening, so lung cancer screening and so. And each team are using totally different model. And it's really nice because you can see lots of amazing things have been created.
Yeah, it must be fascinating to look across the Recite project and see the different outputs from the different the co-development groups.
Yeah, we're trying to create like an exhibition or so later on as well at the end of the project, so we can share it.
Very nice. Yeah, I mean, it's a great resource for researchers to kind of see the types of outputs that we could get from our research if we think about approaching it in a slightly different way. You did mention storytelling at some point, and I see more and more that there are kind of courses and workshops on having storytelling as a research method to be kind of complementary to qualitative work and intervention development. Do you have storytelling expertise on your team, or was there a
Yeah.
particular method you brought in?
Yeah, so there is a storytelling pillar within Recite where some people who are expert in storytelling have conducted a series of workshop with people who have underwent health equity issue within Liverpool, Sefton and Knowsley, and they bought like somebody who's a creative writer and so, and they are trying to collaborate the stories into a small film as well. And this will be used into the advocacy. So the way that Recite work, we try to interconnect everything together. So, and this is why we wanted the voices of the people who have underwent inequity to be heard by the people of the policymaker as well. I can share that also once it's ready.
Fabulous. That's great. Thank you. Any final questions for Noor? I think that's everything. That was fantastic, Noor. It's so nice to kind of see the such engaging outputs and to hear about research with different groups. So thank you again for joining us. And it's a shame that we couldn't meet Reda, but yeah, handing in your PhD thesis is far more important. So we wish him luck with that and with his fibre as well. And yeah, thank you. People can email you if they have any questions after this.
Yeah.
And I hope you get some good results in your follow-up evaluation survey, and some of those percentages come down on those items.
Hopefully, thank you for having us today. And again, if anyone have any question, just feel free to email me. Thank you so much.
Thank you. Lastly, I just wanted to share one slide to tell you all about the next webinar that is going to be coming up next month. Hopefully you can all see this okay. So we're going to have Professor Roberto Laragione from Surrey, who's going to be talking to us about AMS strategies at the farm level. So we've got representation from the veterinary side in our next webinar, and we can have some discussions about how those AMS strategies relate to human health as well. So look forward to seeing some of you next month. Thank you ever so much again, Noor, and we'll stay in touch. Lovely to see everyone online. Bye-bye.
Bye.
Bye, everyone.